in the political system. I don't know whether any of them has even been able to meet with that. But I want you to know that across the world, actually, there was a derailment. I told you that there was this increased specialization. Of course, we will not stop medical doctors from discovering new grounds and specializing. But you know that when they specialize in certain esoteric areas, certain complicated areas, they will not be in the primary healthcare sector. And the nurse that will go assisting him, maybe in cardiac surgery, will not go to the rural area and all that. So that is what we are saying. So we begin to have problem of access again, both financially and geographical. And all these things are going around. That has created another form of inequality. So the World Health response is that they began to talk about certain reforms. And that's how around 2008, universal coverage reform in primary health care came in, because this is still part of primary health care. I want you to know that when you're talking about universal coverage, you are actually talking about that level where everybody can be covered. It's not really everybody that can be covered at the specialist level. Number one, everybody doesn't have that specialist need. So, universal coverage reforms came, service delivery reforms came, where they began to talk about if you are in to the lives of the people. We begin to talk about public policy reforms, where the health system policies to support universal coverage and the effective service delivery comes in. Then you talk about leadership reforms. The truth is that one of the reasons, somebody was just saying, you are telling the chief executive that, look, in a general hospital, there's only one nurse, and it doesn't really make too much sense to him. He doesn't know that it is a very, very acute emergency. Because of the issue of cost containment, it made our leaders to just abandon. Okay, let them go and do. It's a health insurance. It's this other one. So it is still the same World Health Organization that also introduced leadership reforms, in which they are talking about a halfway between leaving it for the people and instituting necessary control so that the thing will not flop. Prof was talking about using contributory, serving that is health insurance to cite the services. It's not possible. It has to come there. The service has to be there. It has to be up to date. It has to render what it's supposed to render. It has to have manpower. It has to have infrastructure. Then people will come and healthcare provision by primary healthcare. It's also, it has dovetailed into the fact that we cannot have universal health coverage, and gender inequality and other inequalities are actually there, becoming inimical to producing that kind of coverage that you need. I've already said, for example, that you cannot talk about primary health care with equitable distribution when you have already said these people are serialized because of their agenda. Are we seeing that it is not comprehensive? And then we cannot also talk about universal health coverage where everybody is covered, but some people are serialized because of the agenda. So that is what is remaining about this discussion. So health inequities, that's a right mix of government policies. Social factors, including education, employment status, income level, gender, and ethnicity, have a marked influence on how healthy a person is. And in all countries, whether low, middle, or high income, there are wide disparities in the health status of different social groups. Yes, next. Health inequities are systematic. No, next. So the bottom line is that gender is a determinant of health, and this has implications for both males and females. Of course, you know, if you are talking about some diseases that are common to men, it is common to men. Those that are common to women, they are common to women. But gender inequality is more negatively skewed towards women in almost all societies and in diverse settings. All these have implications for provision and utilization. I've already given you an example of places where women are harassed sexually because they are women. Even though they are care providers, it is still here today. In some places, women are manhandled. Some of them are beaten up just because of their sexes, whether they are providers or they are users. Continue. So universal coverage and this relationship to PHC provision, it implies that everyone should be able to have unhindered access to healthcare services without having to worry about the money needed to pay for the services. A major focus of this resolution was to reduce people having to rely on out-of-pocket payments for their healthcare needs, and that's what doctor gave us. Took a lot of time to talk about. PHC has been acknowledged. It is still acknowledged in the World Health Report of 2000. From there, when they assessed, they began to talk about universalism, the essential values of PHC, social justice, and the right to better health for all participation and solidarity they have endured. Now more than ever, in interconnected reforms that address the gaps between the promise of PHC and its delivery, universal access and social protection through universal coverage, people-centered, responsive, integrated service delivery, health policy across all sectors, and inclusive, participatory, and accountable leadership. This is where we are, and that's where we are emphasizing healthcare universal coverage. So I wrote that you attain universal coverage through PHC, but you also attain PHC through universal coverage. And anytime it is not done like that, you are having inequality. Yes, next. Gender inequality means equal chances or opportunities for women and men to access and control social, economic, and social resources within families, even though it is not really equality in that sense. It is also known as formal.
Thank you very much, Dr. Peace Iheanacho, for that lucid presentation.
Students may not be able to ask some questions because Dr. Peace took us to a high level crescendo on gender inequality and PHC. Hello. Some of you may be hearing about gender inequality now, gender inequity, health inequities, universal health coverage. Hello. So I won't be surprised if you don't ask any question. But she has done, in fact, if it was in a setting where we have development partners and NGOs, she will have a standing ovation. Hello. Because she went around the whole issue of universal health coverage, health system strengthening, and gender inequality. But I want to comment on somewhere. You know, she talked about equal chances, opportunities for women and men. Health services. People are asking, so me and you believe if you're a nurse, you're in this part of the country, and a gay man comes to you and say, I want to do HIV testing. And you ask him, are you married? And he says yes. And he says, what is the name of your wife? And he says, Mr. Donald Trump is my husband. You will not want to provide that service. Hello. So that's what we are talking about. So for us here, our own gender issues are still related to men and women. However, because of the way the world is going, and we know that the Bible says at the end of the times, a lot of things will begin to take place. So we may begin to see young people who are coming and saying, she's 15 and she's 16 and saying, I want contraceptives. I want to be on contraceptives. I want to be on family planning. Because she's already having sex. And so because she's a woman and because she's a girl, you may want to say, go away. And if she goes away, you don't want to talk to her, you don't want to advise her as a nurse. She will go to the park and probably get pregnant and have abortion and die. Hello. So these are some of the things we are talking about gender. So when we hear about gender, don't say it's only women. We also have men who have issues, whose wives have been giving birth 5-6 children. They don't want to stop because, like she said, they are looking for a boy, and the woman's health is at risk, and the man is saying, what do I do? And so for women, probably because they don't have children, their husbands want to marry other wives, they're thinking of, what do I do when I come to you? Even women at the primary health care level, you see women who are poor and they come to the ANC and you want to test them for HIV and they are positive. Thank you, ma'am. So, Tanzania, please conclude the section and let's go to the next.
Thank you very much. Gender inequality is a serious issue. It cuts across the whole stages of life. You are aware, for instance, somebody is pregnant, she goes for ultrasound scan to determine the sex of that fetus. So gender inequality starts as early as that period. And in some countries, they have banned sex determination antenatally. You don't do it because they know that once they do the sex determination, it is not the sex they want. They will go and abort it. So it has been banned. They stop doing it. When the baby is born, somebody wants to know, is that baby a boy or a girl? When MTN really came to Nigeria some years back, we remember the advert of Mama na Boy. Who remembers Mama na Boy? Some women advocates have to kick against it, and MTN had to withdraw that advert. So it starts from inside the womb to when the baby is born to the adolescence. If I was a girl child in some cultures, you feed the boy child more than the girl child so they can grow and become a very big man. And you think you will not give too much protein to the girl. In adolescence, issue of contraception, she's being battered in the home. It's also a form of gender discrimination. So it's an issue that we have to take seriously. There must be equity when it comes to gender. A woman must have equal access to health care as a man. And for us to remove the barriers, it has to start from the grassroots. Very first point of call when it comes to health care, that's the primary health care. That is what the speaker has said exhaustively this afternoon. Thank you very much, Dr. Peace. And a round of applause for her once again for that beautiful presentation. Thank you very much. So on this note, we conclude that session. Please, I must announce that there should be no going out. Student nurses should please stay and enjoy the program. I think some people are going out, especially student nurses. They are requested to remain seated while this program lasts. and enjoying the contents of the discussion. Thank you very much.
By name, Dr. Mrs. Abo. Dr. Mrs. Abo is a consultant community physician. She will say the rest as she comes up. Thank you. And she is taking us on the topic, rethinking primary health care services and the nursing profession. I know that you people will listen attentively at this time. Thank you. You're welcome.
Thank you, ma'am. Thank you. Good afternoon, all. It's been a good day. We've had a lot of lectures today, and I hope I can handle this topic as well as others did. My name is Abu Uridnachi. I'm a mother of 3. That's all I always tell people. But also I have this passion of being a public health physician. And one thing I tell people about public health is that it gives you the platform to just widen your scope. Especially if you do not like routine, where every day you just come to the clinic, you see a patient, you catch drug, you go. Public health gives you that base in such a way that once you understand what you're doing as a public health nurse, nothing stops you. You go places on your own. So, but we can pick out certain elements when we are looking at the definition there. Is an essential health care. It has to be practical, it has to be scientifically sound, socially acceptable, the methods and the technology, of course, and then universally everybody will access it. The families, the communities, nobody is blocked from accessing it, and then they participate fully in it at a cost that they can afford, in the spirit of self-reliance and self-determination. When you're talking about self-reliance, that person in the community ends up feeling all these things that are non-health factors that still affect your health. We still talk about them as part of health. And then that's when we now look at the different levels of the health system. When we say we have the micro level, we have the meso level, and we have the macro level. If I say the micro level, I mean you and I, the relationships existing between you and I, the individuals in the health system. So that woman who is carrying a baby and breastfeeding that baby in order to ensure that that baby is alive is part of the micro system. She is part of the health system. So if there's anything she does to that baby will do what? Die. And it will reflect in our health indices, in the infant mortality. Simple.